Hi, I'm Rebecca Marshall. You know, it affects 1 out of 2 women. We're talking about urinary incontinence, and nobody really wants to talk about it, but we're going to do that today with Dr. Richard Rosenfield, a board-certified gynecologist and surgeon at Pearl Women's Center. Hi there.
Hi, how are you?
Good, doing well. How does urinary incontinence happen?
How does it happen? It depends on the root cause, of course, because maybe before we talk about how it happens, we can define it.
Yeah, what is it?
So within the world of urinary incontinence in the female patient, there are a couple of different types of incontinence. Most women are familiar with the TV ads that are out there, you know, the kind of gotta go right now. You've got a woman in a jury box that is looking around because she needs to run to the bathroom. That type of incontinence we define as urgency incontinence, and usually that's a bladder capacity problem. Oftentimes in that world, it's due to a variety of factors, but essentially the bladder is overactive, and we'll maybe get into what that means in a little bit here. The second type of incontinence is called stress incontinence, or stress urinary incontinence, and that is a mechanical problem, meaning that you cough, you sneeze, jump up and down, jump on a trampoline, try to pick up a child, and you leak urine. Typically, the difference between the two, urgency incontinence is this feeling that if you don't get to the bathroom, you're going to lose your whole bladder. Whether or not that actually happens, it's that sensation that we're dealing with when patients say, you know, I have frequency, I go to the bathroom, you know, every 20 minutes, whatever, the frequency that might seem a little bit too often for those patients. The stress incontinence is one where we typically hear that a patient's wearing a pad or some sort of undergarment because every time they cough or sneeze or jump up and down, exercise, they might leak a little bit. This is a problem that women start altering their activities. They decide that they're not going to play tennis or golf anymore or run because they leak urine. And so once we define that, then those two can also be mixed where you have both types of incontinence. There's a third type of incontinence where there's a problem with the urethra itself. That's more of an issue that we deal with in elderly patients where there's just chronic leaking all the time. That is almost always a surgical fix. Typically, these are patients that have had radiation or some sort of other treatment to their pelvis that's led to that. So in our practice at Pearl Women's Center, we typically are going to see the first two, the urgency incontinence and the genuine stress incontinence, which is the one with the coughing and sneezing.
Let's break it down, the urgent one. How would you treat that?
Urgency, typically we have to get a very good history and physical. This could be something that's as simple as the patient just not managing their fluids very well, you know, drinking a ton of coffee. I mean, here we are in Portland, you know, your triple grande coffee.
I'm 10 cups in right now.
With that, alcohol. There's a lot of things that can be bladder irritants, and those bladder irritants can give a patient the sensation of needing to void. Oftentimes with urgency incontinence, we can fix this with bladder training, where we teach patients how to regain control over their bladder. Rather than letting their bladder control their day, we try to essentially overpower it with our brains. If that doesn't work, physical therapy can be helpful, and certainly medical management. And this is where those TV ads that we were referring to come into play, because there are drugs that are out there that can block the receptors in the bladder that make one feel that they have to urinate quickly, okay? In stress incontinence, most of the time we're dealing with women that have had kids, okay? So there is a structure underneath the urethra that in a woman that hasn't had kids, this is intact. And what I mean by that is that there's nice strength in the pelvic floor, so when somebody coughs or sneezes, there's a transmission of pressure from the abdomen down into the pelvis, and we maintain dryness. When a baby passes through the vagina and things stretch or pull or break, what can happen is the support underneath that urethra can become lax. And when that happens, when a patient coughs or sneezes or bears down, the pressure in the bladder overcomes the pressure in the urethra, and leakage happens, usually in small quantities. But it can be very, very distracting, as you can imagine. And as we've talked about with previous topics, this is not something that people are commonly comfortable talking about. So it's important to let people know that if you're leaking urine, this can be fixed, and it can be fixed effectively, typically with surgery if it's a significant amount of leakage, although if it's just a minimal amount of leakage, sometimes getting a patient in for physical therapy can be helpful. And as we know, you do a better job going to the gym if you have a personal trainer. It's the same thing with Kegel's exercises. You know, these are those tightening exercises that we talk about, where if you're, you know, on the toilet and you have the most important phone call of your life across the room and you need to get to the phone, it's that muscle that you would use to stop urinating. That's a Kegel's exercise. We know that if you have a trainer, and that trainer would be a physical therapist that understands pelvic floor anatomy and muscles, that physical therapist can be very, very helpful at making improvements in this type of problem. Although many times that's not enough. And if it's not enough, we start looking at surgical intervention. The way we get there is we do bladder testing. So a patient comes into the clinic, they give us this history, we do an exam, and then we do something called systometric testing, where we try to reproduce this problem. We literally fill the bladder with water, and we have the patient bear down, and we see what's happening, okay? And this is something that we do with Kyle, my nurse practitioner at the Pearl Women's Center. And it's a little bit embarrassing. We talk to patients about what they're going to experience that day, but we have to reproduce the problem so then we know how to treat it. If we see that it's just run-of-the-mill stress incontinence, which is very, very common, there are some amazing new techniques that are available that can cure this problem with a quick outpatient procedure, as opposed to what we used to do, which was a major surgery in the hospital.
So getting back to the Kegel exercises, does that help build the pelvic floor so you don't have that problem? I mean, that's something, frankly, you could do at home as well, right?
Absolutely, it is. And Kegel's exercises are things, and we can see that, maybe we're doing them as we talk. This is something that can happen anywhere, right? You can do your Kegel's exercises. The thing about Kegels, though, is they may not get you where you need to be. And so it's a great fix for patients that have a small problem. But if there's literally torn ligaments in the pelvis, a Kegel's exercise is not going to rebuild a torn ligament. That gets more into an issue of pelvic organ prolapse, which is where it's not just the support around the urethra, but the support around the vagina, the support around the cervix, the support around the uterus. The entire pelvic floor literally can be dropping. And when that's the case, we need to do a more significant evaluation, because oftentimes there's a more significant operation that needs to happen, although all these things can be done with these minimally invasive techniques that we refer to.
We talked about it last time, we want to give context to it. So in giving context to this, you sort of have to say things that are sort of uncomfortable. But in terms of women who have had children and now they have a full bladder, and on the way to the bathroom, sometimes some leaks out. Okay, let's just say that.
Sure.
Is that a situation where they should come see you, or is that one of those, that's just normal after you've had kids?
Well, I think that anybody that notices that they're changing something with their lifestyle because of a urinary problem, especially in a big city like this, going to a physician and having a consultation is a completely reasonable thing to do, because it might be something that is a minimal problem that we can just educate the patient on how to make this better, where they can make little changes during the day, or little things like maybe not drinking as much water as we hear we should drink. Everybody's drinking,
64 ounces
everybody's
a day,
got their
right?
aluminum water bottles,
Yeah.
Walking around Portland. Well, if you keep drinking and drinking and drinking after dinner, you may have some trouble at night not being able to get through the evening without getting up several times to go to the restroom. But for patients that have a more significant anatomical change, like after having kids, oftentimes there is a surgical correction that's required if we really want to eliminate this problem from somebody's life.
Okay.
But that requires an exam. We can't just make that diagnosis over the phone.
What does that look like? What does surgery look like?
Well, it depends on the problem. We have to identify the source of the problem. So if it's isolated incontinence, we can do a very simple procedure called a suburethral sling. We make a very tiny incision underneath the urethra. So this is a vaginal incision. And then we put this little thing, it looks almost like a shoelace, right underneath the urethra. And it's made of mesh, which is a permanent, it's like a thread, a monofilament thread. And that mesh goes underneath the urethra, so then when the urethra drops, it drops onto something. And that way, when a patient coughs or sneezes, they stay dry. If there's prolapse, which is a more significant problem, we have to identify specifically what ligaments have torn and where the defects are, and then we go in and we repair those defects to restore normal anatomy. Those defects might be causing problems with bowel movements. They might be causing problems where a woman feels that she's going to the bathroom and then she stands up and has to sit right back down and go again. The reason sometimes is because the bladder is bulging into the vagina, and sometimes people even have a sensation of a bulge in the vagina, and that might be something that we need to fix surgically as well. The good news is that we've come a long way with these surgeries. When I was a resident in training, all of these things, including incontinence management, were open, big surgeries at the hospital, 3 days in the hospital minimum, and then a good 6 weeks, if not longer, for recovery. We've been able to take all of these things, and without losing any effect, we've been able to move this into an outpatient situation. Even with the most complex pelvic floor disorders, we're able to do these with a laparoscopic approach to restore normal anatomy and do this in a relatively painless way.
Yeah, I was going to ask with the mesh and the new thing inside your body, do you have to rest a while so it can settle in, so to speak?
Well, there's going to be some restrictions, especially if there's been any work done vaginally. We have to, it's not really pelvic rest, it's more no intercourse for 6 weeks. But as far as return to work, a matter of days. And with the suburethral sling, this is a very easy procedure and it's painless. The prolapse work is more complex, but still, patients get through it and they get back to work quickly, and then this problem is fixed permanently if we do it correctly.
I know with elderly patients, at least a friend of mine's grandmother used to have to go, like she'd just go, have to go, and then nothing would come out. What does that fall under? What category?
Well, that would be urinary retention. And typically retention is going to be due, it depends, once again, on the history and physical. So this could be a neurologic problem. It could be, that maybe this elderly patient had diabetes and hypertension and some other medical problems that were having an impact on their ability to control their bladder. It also could be an anatomical defect. And so, once again, kind of getting into situations like this, most important thing is saying, hey, you know what? I'm not having a normal urinary life. My urinary system is not working the same way as my friends. So maybe I should go see a doctor about it, because we don't expect patients to be able to self-diagnose with complex medical problems like this. So what we want to do is educate people and say, listen, if you're having trouble, come in and see us. And we'll tell you if there's a problem. And if it's a problem we can fix with medication, fantastic. If we can't, we may have to look at surgical options, maybe not.
I was just going to say, there are people watching this that are saying right now, oh, I can't do it. I just can't. I'm too embarrassed, even though my life is completely altered. You kind of touched on it, but what would you tell them?
I tell them that, this is something that we see every day. And the fact that we sit here and candidly talk about it, that's what we're going to do at the office. We're going to talk about it like we're talking about the weather, because it is plumbing. And it's as simple as that. The body's a machine, and this is the plumbing system of the body, and the plumbing system needs a repair. It's that simple, and we can fix it and make this a non-issue. So I think the main thing is, just embracing the fact that this is not normal, and seeking help from someone that you feel comfortable with. And really the most important thing in this particular subset of problems is seeing a provider, a physician that understands the mechanism and also has the expertise to fix it.
Yeah, and 1 in 2 affected in their lifetimes. It's not that uncommon.
It's a pretty amazing statistic when you hear that upwards of 50% of women are going to be affected with some sort of incontinence during their life. It's a big deal. It is a very big deal.
Urinary incontinence, that's what we're talking about here with Dr. Richard Rosenfield from Pearl Women's Center.